Hello everyone, and welcome to today's live broadcast, Post-COVID-19 Condition, Best Practices on Management for Clinicians and Patients. I'm Dr. Natalie McDermott, and I will be your moderator for today's event. Among the most troubling outcomes of the COVID-19 pandemic has been the thousands of reports of patients living with persisting symptoms or post-acute sequelae of SARS-CoV-2 infection, also known colloquially as long COVID. Many of these patients continuing to express symptoms or experience symptoms for weeks, months, and perhaps even longer than a year in many cases now. These patients continue to experience a wide variety of persistent symptoms, from fatigue, cognitive dysfunction, or brain fog, as it's also known, and shortness of breath, to muscle and joint pain, sleep issues, and more. What is known about these prolonged health consequences, and what does the spectrum of recovery from SARS-CoV-2 infection look like across different populations? What do we think that the underlying biological causes might be? And does the COVID-19 vaccine have any effect on these lingering symptoms? Tonight, we're hoping to answer some of these questions with the help of our expert panel, who will be speaking shortly. So just a few housekeeping messages. This is a live programme, and it's presented in partnership by the International Society for Vaccines and MJH Life Sciences, which is the home of such brands as Contagion, Neurology Live, Practical Cardiology, and Psychiatric Times, to name a few. So just a few notes before we begin. This webcast is designed to be interactive, and we would like to encourage you to submit questions using the Q&A tool underneath the video player. Towards the end of the presentations, we will take about 10 to 15 minutes worth of questions from the audience. And I will present these to our panel so that they can provide their insights into the questions that you have burning in your minds at the moment. The slides will advance automatically during the event, so you don't need to worry about that when you're watching. But if you have any problems viewing or hearing the webcast, please click on the support icon to report your issue. So a little bit about myself. I am a paediatric infectious diseases doctor, and I work here in the UK in the National Health Service. I'm also a clinical lecturer at King's College London, and my research background is in epidemic and pandemic diseases. I also have some ongoing health problems following COVID-19, so I am able to empathise with many of you who are joining this webcast. I would now like to welcome and thank my colleagues who will be joining me this evening and ask them to introduce themselves. So, Dr. Iwasaki, please would you introduce yourself to the audience?
Hello, everyone. I'm Akiko Iwasaki. I'm a immunologist at Yale University School of Medicine. I'm very happy to be on this panel to discuss some of the basic pathogenesis questions on long COVID. Thank you.
And Dr. Zandy, would you be able to introduce yourself, please?
Thanks, Natalie, and everyone. Thanks for the invitation to this event today. Really looking forward to hearing it. I'm Mike Zandy. I'm a neurologist in Queen's Square National Hospital for Neurology and Neurosurgery in UCL in London. And I'm part of the long COVID clinic in UCLH. And we also have a COVID neurology clinic that I'll talk a little bit about in my presentation. Thank you.
And Dr. Yojishi, would you please introduce yourself?
Thank you, Natalie. So, hi everyone. So it's really a pleasure to be here this afternoon. I'm a consultant neurologist and the clinical lead of the autonomic unit at the National Hospital at Queen's Square. And I will discuss the autonomic dysfunction in a long COVID syndrome. And
Dr. Bell, would you introduce yourself, please?
Thank you very much, Natalie. My name is Dr. Bell. I'm an academic cardiologist based at the University College Hospital. I've got an interest in the COVID, and I work with Michael and Valeria with the long COVID clinic based here at UCLH. And looking forward to hearing the rest of the program. Thank you.
And Dr. Petrino, please could you introduce yourself?
Absolutely. Hi, everyone. My name is David Petrino. I'm a physical therapist working at the Mount Sinai Health System, and my team has been responsible for managing rehabilitation of thousands of long COVID patients.
So I will now hand over to Dr. Iwasaki to get us started with the presentations.
Thank you. Can you see my slides? Yes? I assume. Okay, thank you. So yes, I am going to be talking about some of the disease mechanisms and what we think about in terms of how long COVID might occur. And so the long COVID has become a major problem, as already discussed by Natalie. It is really affecting a large number of survivors. Long COVID patients experience myriad of symptoms for weeks and months after infection. And there are many different estimates of how many people with COVID infection become long haulers, but there are numerous symptoms, including fatigue, exertional malaise, and cognitive dysfunction that are found in these patients. There are also evidence for multiple organ disease and damage, as well as common effects on young and middle-aged females. And I'll get back to that a little bit later. And about 20% of COVID survivors are thought to develop long COVID, even those who are not hospitalized. And for hospitalized patients, it's even a larger percentage. And many of the long haulers are experiencing debilitating disease. 45% of cases requiring a reduction in workload, and 22% are just unable to return to work. So this is a major problem going forward, as even if the vaccines are able to contain the infection and spread, we will still have to really find out what's causing this long haul disease so we can provide appropriate care. So so this slide is basically insights that was shared to me by Dr. David Petrino, who will speak later today. But essentially, there are two kinds of long COVID we can think about just as a framework to try to understand disease pathogenesis. One is the severe COVID, who are patients who are hospitalized as a result of COVID that are discharged. And a large percentage of these people will have long-term symptoms going forward. And this is a post-severe COVID-19 syndrome. There may be organ damage, tissue damage, fibrosis, and post-ICU problems in these patients. And there are also the second category of mild to asymptomatic COVID, also resulting in long-haul disease, even after the viral load is no longer detected in these patients. And this post-COVID-19 fatigue syndrome obviously includes a lot of the symptoms that I will describe today. But if these patients have prolonged symptoms for over 6 months, they may develop ME/CFS-like syndromes. So today I'm going to focus mostly on the second category of long COVID. This includes a large number of patients, as I described, about between 10 to 30% of people who had mild to asymptomatic COVID. So there are over 200 symptoms that are reported for long COVID. Here are some of them, the common ones that are listed. And it involves multiple organ systems, including systemic, neuropsychiatric, head, eye, ear, nose, and throat, endocrine, cardiovascular, pulmonary, musculoskeletal, and GI tract. And many patients have multiple symptoms that are ongoing for an extended time period. And long COVID symptom and severity can be observed in a number of patients. And the types of severity that's listed here on the left shows that the severe, very severe to severe patients tend to just decline over time, but are taken over by moderate to milder symptoms over several months. And also those who recovered within 90 days of symptom onset appear to have had less average number of symptoms compared to those who have prolonged disease. So we think of long COVID disease as having at least two different causes. One, this is hypothesis at this point. We don't really know who has what kind of long COVID, but we hypothesize there may be viral reservoir that are present in distinct organ tissues that might lead to inflammation and damage. The other type of long COVID disease might be induced by autoreactive lymphocytes, such as autoantibodies and T cells that are specific to different target tissues. And this could also have a very long-term consequence of varying symptom types. There is evidence for both of these types of causes. For instance, if you look at the viral reservoirs, there have been reported to be viral antigens that are present in the intestine of people who've had COVID for 3 or 4 months. And you can see that there's nucleocapsid staining, as well as they detected PCR from 3 out of 14 patients. So this illustrates that there may be viral reservoirs that are present that are undetectable by nasopharyngeal swabs that may be causing inflammation. There's also autoantibodies in COVID-19. So I was fortunate to collaborate with my colleague, Dr. Aaron Ring, and his laboratory to determine that there are a number of autoantibodies that develop during acute COVID. And we are now seeing a number of autoantibodies in long COVID patients as well. So just to briefly to go over the technique that Dr. Ring's lab has developed, it's called Rapid Extracellular Antigen Profiling, or REAP. And it allows us to look for autoantibody by incubating a patient's sera, IgG, with a yeast display library that contains over 3,000 different extracellular or secreted proteins, or exoproteome. And the yeast cells that are bound by the antibodies from the patients can be pulled down and then sequenced to identify what kind of autoantigens they were reactive to. So through this REAP technology, we identified a large number of autoantibodies that are associated with both immune cells, immune factors, as well as wide range of tissue-associated proteins that are expressed in the brain, vasculature, cardiac tissue, hepatic tissue, GI tract, and many other tissues. So there is evidence for this kind of autoantibody to develop during COVID infection that could lead to long-term consequences. And in addition to this, there are many other reports now demonstrating autoantibodies in COVID patients. This is not an exhaustive list, just some of the ones that I was able to come up with, but there are many others who are reporting autoantibodies in COVID disease. So the question is there anything, are there any treatments that impact long COVID symptoms? And I know there are many investigators that are trying to figure out this problem, and there may be some treatments that are ongoing right now. But the one that caught my eye was the vaccination. So a large number of people getting the vaccines as a long hauler have felt difference in their symptoms. Many of them feeling improvement in their symptoms, while others have no symptom difference, or some having worse outcome as a result of COVID vaccination. And this is a report that's available through the Long COVID SOS website. There are many, many very useful figures in here. I just chose a couple to demonstrate that all of these vaccines that are studied here are the adenovirus phase based vaccine in blue, Moderna in orange, and Pfizer in gray, they all show about the same level of improved symptoms. And similarly, no change as well as worsening of the symptoms are pretty comparable between these types of vaccines. When you look further into the different vaccines and different symptoms, you see that there is some variation with respect to how long haulers are feeling after getting a particular vaccine. And you can find more about these changes in that website. However, the fact that long COVID SOS as well as other patient-led groups are reporting a difference in symptoms after COVID vaccination, we decided that this is an important area to investigate, because through vaccination, we may be able to uncover what the underlying cause of disease is by studying the immune response of these patients, people who are having long haul disease. So the hypothesis that I described to you, the viral reservoir or the autoantibody responses and autoreactive T cells, they may be impacted by vaccines in different ways. For instance, we know that the vaccines elicit robust antibodies and T cell responses that could clear the viral reservoir, and that will eliminate the cause of inflammation. Second, it's also possible that the cytokines that are induced by innate recognition of vaccine component, as well as adaptive immune cells secreting cytokines, could lead to dampening of autoreactive cells. This may not lead to a permanent cure, but may lead to a temporary relief from some of the symptoms. So our mission is to understand immunological and physiological determinants of disease pathogenesis of long COVID to inform rational diagnosis and therapy. So we are fortunate to have established two different cohorts to study long COVID. First cohort, cohort A, is a cross-sectional long COVID cohort that is really a close collaboration with Dr. David Petrino, who will speak later today. And here we've already collected over 100 patient samples in order to try to understand the disease pathogenesis. The second cohort is a longitudinal long COVID vaccine cohort, where we are studying changes in immune responses in the long haulers prior to and post-vaccination, and to correlate those changes to the symptom differences that they feel afterwards. And this is a close collaboration with Dr. Harlan Krumholtz's laboratory. So just to quickly introduce the key players in these cohorts, the Mount Sinai collaboration is with Dr. Petrino and his colleagues listed here. And then the second cohort is the Yale Recovery Vaccine Study, in which Harlan, as well as many collaborators, are leading the charge here. And this is important to emphasize that we've had a very close collaboration with patient-based groups, including Survivor Corps and Patient-Led Research Collaborative, in order to design the study and to carry out the study. So it's a real equal partnership. For the Yale Recovery Vaccine Study, we are, as I said, collecting pre-vaccine and post-vaccine samples from long haulers and try to understand their changes in the immune responses that may be leading to either improvement or worsening of the symptoms. So quickly, the workflow that we're using is to recruit patients into these two cohorts with the help of Survivor Corps and other patient groups. And then we're doing immune profiling and then storing some of the samples for further analysis, including metabolic and T cell receptor, B cell receptor sequencing, and as well as hormone profiling. And the investigators that are listed below these efforts are collaborating with us on these efforts. And then once we have this thousands of data points from each patient, we're going to integrate these using multimodal and multi-omics approaches for data analysis. And we've also been able to recruit excellent investigators in that field. And finally, we want to return the results back to the patients so that they understand what kind of data was resulted from this effort together. So I'm going to end here by thanking the members of my laboratory, as well as the various cohort and their team members for enabling all these studies. And I'm happy to take questions later. Thank you.
So I think we will move on to Dr. Zandy's presentation.
Can you hear me? Can you hear me now? I was just muted. So thanks again. Let's get my slides. Great, and can you see my first slide? You can hear me? Perfect. So I'm Mike Zandy, neurologist and neuroimmunologist at Queen Square in London. I list my conflicts. I'm a PI on various studies related to hospitalized patients with COVID who've had brain involvement, but also a new to start long COVID study funded by the NIHR here called Stimulate ICP, which is based in UCL. And this is the National Hospital in Queen Square, which is in Bloomsbury in north central London. And we started off in the first wave in England in March 20, started to see patients who had COVID and neurological complications. And I'll start by talking about what we saw in the neurological complications of all COVID, focused bias towards hospitalized patients, and then how we're seeing now more patients who weren't hospitalized. And this is a team of us, including neurologists, who for the last 5 years, we've been looking at the interface between neurological illness, but also infectious diseases. And we had a monthly meeting where we discuss what had been hitherto rare disorders of encephalitis. People had cognitive changes, sometimes seizures and fevers, in whom the diagnosis could be brain infection, or it could be the immune system after an infection, or even sometimes associated with a cancer causing inflammation of the brain, sometimes leading to symptoms that are very psychiatric in nature, and we'd see people across the spectrum who could have a unifying diagnosis. And I co-chair that meeting with colleagues Hadi Manji, who has led this work from the 1990s in HIV neurology, Patricia McNamara, who also runs the long COVID neurology clinic and is the key clinician for that clinic here at Queen Square, and Laura Benjamin, who has a lab looking at viruses, HIV and stroke. And we have neuroradiologists, peripheral nerve and neuromuscular junction specialists, trainees, infectious diseases doctors, neuropsychiatrists and cognitive doctors and our students, and also other alumni and members in the lab, Professor Angela Vincent, who led a lot of work of brain-related autoimmunity in the early 2000s, describing some of the first patients who had limbic encephalitis, which we've seen rarely in COVID, but maybe is an antibody-mediated link for some patients. Many, we were horrified to see the original reports, and in England we saw the effects in Italy, and then very shortly in the UK in March, and how different groups across the world had seen much of the same thing. And we reported in the summer of last year, the first 2 months of our experience at the National Hospital, where that original monthly meeting turned into a weekly meeting, and it was a virtual one, where clinicians around the country will report patients who had COVID, by and large, were in hospital. This dominated the meeting now, and often had unusual presentations, but we started to be able to unify those. And we saw a significant group who are significantly encephalopathic or delirious, often younger people with low blood oxygen levels who'd come in after having COVID. And you have to remember this data set is very biased to who are the patients who are puzzling usual that were being referred to us and who had brain imaging. And by and large, this first group but also in a way, by definition, they had normal brain imaging, normal lumbar punctures when done, and we didn't see any definite evidence of brain inflammation. We then saw a large group of those where there was evidence of brain inflammation, and this looked very much like previous post-viral types of brain inflammation of a disease called acute disseminated encephalomyelitis that was first really well described in the 1920s after the 1918 influenza pandemic, but has been associated with vaccination and with other organisms as well in the past. And then we saw a substantial number of people who had aggressive stroke. These were people who were sick with COVID. They had very sticky blood, proteins in the blood that were really elevated, clotting factors, and they'd have really aggressive stroke. So they could have a small stroke, were put on blood thinners, they would clot up an artery in the neck and then have another stroke. And half of them in this, our initial experience, also had clots in the body elsewhere, for example, in the lungs. And then we saw inflammation in the peripheral nerves in the arms and legs, the Guillain-Barré syndrome, but also the brachial plexus. And colleagues in Cambridge saw an excess of people with vasculitic or inflammatory nerve illnesses, sometimes put down to being in the intensive care unit, having proning. But if you look in more detail, and one of the messages I think we do need to look in more detail, you would find patterns that were not consistent just with compression. And then we saw a miscellany with optic nerve involvement, papilledema, cranial neuropathies. And this is, for example, the imaging in some of those patients with encephalitis. And this is one patient on the top who had a limbic encephalitis. So these are patients who usually have antibodies to synaptic antigens in the brain and can have psychosis, seizures, cognitive dysfunction. They can have an indolent course over 6 months. And they often have antibodies, for example, to the NMDA receptor or LGI1 protein. And we've seen a handful of those seemingly triggered by COVID. It can be triggered by other viruses. This is a group of patients with this ADEM, this acute disseminated encephalomyelitis. And often these patients were sick in the hospital. They were failing to wake up from the intensive care unit. And separate to the usual ADEM that we see, which can be like a monophasic form of MS, though it's different to MS, it can be associated with myelin oligodendrocyte antibodies, MOG antibodies. We've seen a few more of those with COVID, and it's important to look for those. But these patients also had some stickiness of the blood and ischemic lesions within the inflammatory lesions, which is very interesting, and also abnormalities in the splenium of the corpus callosum. And very rarely we'd see people with what looked like a necrotic encephalitis, and maybe that was due to viral infection. But by and large, most of the patients seem to have that syndrome after infection with the respiratory form of the virus. And in some, they weren't hospitalized with the respiratory form. So this looks like an immune process which was post-infectious, actually a trivial COVID in the initial forms, a trivial ischemic or a trivial respiratory illness, but then having a more devastating neurological illness a month or so later. This is the Guillain-Barré syndrome, which we saw, and you can see looking at England in 2020, which has now been published by Steve Keddy and Mike Lunn and colleagues here. And if you look at the rate of COVID, in fact, we saw fewer cases of GBS in the end than we had in previous years. However, this may be due to confounds that we weren't seeing all the other regular viruses in circulation due to measures such as lockdown efforts that we had. And so there is some evidence, I think, that we have seen cases of GBS triggered by COVID, but actually, given the vast numbers of patients who've had COVID, we haven't seen the substantial numbers of patients with Guillain-Barré than we would have expected. And there isn't as strong a link as there is, for example, with, say, the Zika virus. And then we've done some basic research, very preliminary, on that initial cohort and related patients. For example, looking at degenerative markers in the spinal fluid, because this is really to answer the question, are we going to be seeing something like an early Alzheimer's disease after someone has had COVID? and also to look at factors such as other autoantibodies related with blood clotting led by Laura Benjamin that I mentioned. And we have seen some tantalizing things, but in very small numbers. We've perhaps seen some excess of some phospholipid antibodies subtypes in the hospitalized patients who had ADEM. And we have seen subtle changes, but not significantly raised neurofilaments in, for example, those who were in hospital who didn't have significant ITU stay, but those who had significant brain damage, we did see this. And so what we really need is now longitudinal studies to look at those who weren't in hospital and to look at cognition in the long term. And we're discussing long COVID, and we've had a good introduction from Professor Iwasaki there. What we're seeing now in neurology, the question, the unmet need really is, are we seeing brain disease? Is this a neurological disease, or is the neurology part of a systemic illness where you can have neurological symptoms due to systemic inflammation and immunity, or viral persistence, or what other metabolic or other mechanisms may be at play? And in our experience in the neurology COVID clinic, thankfully, the majority of people we're seeing now, we're seeing few cases of stroke or ADEM or significant brain involvement. But we do need to investigate patients because people can look very similar to each other and you can't tell. And I think there can become a false dichotomy of some people, you'll hear in the literature or on the internet say, well, long COVID has to be the exclusion of pathology to diagnose long COVID, but I don't think that's right. And I think we see people, and there is pathology there to be found. And this is very similar to our experience in autoimmune encephalitis with, for example, psychosis. We've looked for people who've had a diagnosis of schizophrenia, and you can sometimes find an autoimmune encephalitis that has been hidden and masked in that diagnosis. So that's not to say that everybody with schizophrenia has autoimmune encephalitis, but that at the beginning, it's very hard clinically to make that judgment without research, without investigation. Because this is a, not to upset you, but this is a tantalizing elephant in the room, is, are we going to see what we saw 100 years ago, an outbreak later of encephalitis lethargica, post-encephalitic Parkinsonism, Alzheimer's disease, and dementia after COVID? Well, generally, to try to reassure you, we haven't been seeing this so far in the last 18 months or so, and we would have expected to see significant numbers of people, like with the Guillain-Barré, with de novo Parkinsonism and other problems, and we just haven't seen that extent. But of course, it's early days, and we need ongoing surveillance. And for example, two papers that speak to that I'm not involved with are a retrospective study of 250,000 people in the States done by colleagues in Oxford, where they showed that the hazard ratio of having dementia or Parkinson's disease was around twice the risk compared to, say, influenza or other respiratory viruses. But this is very muddy epidemiological data, is never perfectly matched, and it's very hard to dissect that from, would you be finding individuals who in the next 5 years would get a diagnosis of Parkinson's or Alzheimer's anyway, and now you've put them through the stress of having COVID, all the stress in the body, and that's manifested a diagnosis earlier on. And again, the difficulty of looking at this was mainly electronic hospital records remotely and not detailed clinical phenotyping. This is an interesting study from the UK, a biobank study, where around 800 individuals had an MRI done and some cognitive tests at baseline, and then 400 of them had COVID, and then they were re-imaged. And in fact, there were some findings to suggest some changes in cognition. These were attentional tests, the TRAILS scores, A and B scores, a concentration test, a subcortical test were impaired in those who had COVID. And also there was possible atrophy, or at least changes in brain plasticity, looking at structural MRI, but also diffusion MRI, mainly on the left-hand side in the insula, the orbitofrontal cortex, and the perihippocampal cortex. So So this doesn't show definite dementia. We really need definite evidence of structural brain atrophy that's progressive with time. But of course, these are findings of concern and do need to be looked at. And in both of these groups, there are patients who weren't hospitalized as well as hospitalized patients. This is our UCH COVID clinic around when we published this paper, led by Melissa Heitman. We found, looking at 1,300 individuals, we found, and this is very small print here, we found cognitive symptoms, brain fog in around a fifth, but we're now only starting to really phenotype these individuals deeply. And it's very hard. One of the lessons from the neurology clinic is that you can't have a neurology clinic, in my view, and then a physical health COVID clinic that's a separate entity. You need to combine the two, and you can have significant cognitive symptoms with a normal brain scan. And the majority of our patients who've had that as an isolated complaint without any other red flags, without focal neurological signs, have had normal brain imaging. But you can't disentangle that from ongoing systemic illness, and often there are blood abnormalities, respiratory problems. And very much there's an analogy with systemic lupus erythematosus, where we've seen individuals who have very rarely, a vasculitis in the brain, quite commonly brain fog, cognitive symptoms, depression, which can mostly be linked to systemic inflammation in the body, but quite rarely, though possible, linked to actual inflammation or illness going on in the brain. And I think lupus is a nice analogy because we see the vasculopathy, we sometimes see similar investigations, but I'm not saying that we should be giving lupus treatments, hydroxychloroquine or steroids outside of a randomized controlled trial. And there can be stigma, there can be problems with the psychological symptoms that often are tied up with the autonomic symptoms, and part of this virus, very biological symptoms. And that's something that we need to look at in holistic care. So 2 studies that I'm involved with, and we're involved with here in UCL and in England, this is a surveillance study, CoroNerve, and a UKRI-funded COVID CNS study, where we're looking at those individuals who had neurological or psychiatric complications of COVID. And this was funded last year and has been started for a couple of months now, and was really biased towards hospitalized patients, where we've seen stroke, encephalopathies, delirium. And I should say in that Oxford study of looking at the increase of dementia and other things after COVID, that was really enriched in those who had an encephalopathic episode. And then this study, the Stimulate ICP study, which is just about to start, which is comparing what the care should look like for those who've had long COVID, looking at enhancing community care, looking at research imaging, but also trying to find the mechanisms. And both of these studies involve biomarker work. But in this one, there's an embedded randomized controlled trial of treatments to see if we can try to underpick mechanisms for COVID. So in the long COVID neurology clinic, we really take things on face value. We think patients deserve to have a neurological assessment and as appropriate investigation as required by the history and the examination. It's hard with resources to say everybody everywhere in the world, and there's so much health inequity that our Stimulate ICP study is trying to address too, say that everybody needs an MRI scan and a lumbar puncture. But if we feel it's indicated on the basis of the clinical syndrome, we go on and do that, and autonomic testing, which Valeria will describe. We think that a close working in an MDT with allied health professionals, the research side has lots of patient involvement. And then treating what can be triggered common phenomenon in neurology, which we've seen, for example, in concussion as well. So we do see migraine, which can sound trivializing, but this could be changes in blood flow and electricity. They can be contributing to the fatigue and the cognitive symptoms, sometimes the vestibular syndrome symptoms, and can respond to migrainous treatments. And we think it's important to look and address the psychological component of being unwell and having an illness, because that gives us the best rehabilitation, as we've we've mirrored this on our encephalitis clinic or for those with other brain illnesses. So I'd like to finish by acknowledging that I'm just one member of many in the team. Two others are with Valeria and Rob here today, but this is really a multidisciplinary team that was started while it's over a year since we started the long COVID clinic in UCLH, and has been learning as we've been going along. So thank you for your attention.
So can I invite Dr. Iodici, followed by Dr. Bell, to give their presentations now, please?
Thank you, Natalie. So can you see my slides? Yeah. So we will discuss the autonomic dysfunction in long COVID syndrome, and with a focus on our experience in UK. So a brief presentation of the autonomic disorder and which domain they do involve, which are the most common autonomic dysfunction in long COVID, and a brief case-based presentation and the management of POTS. So the autonomic nervous system does innervate each and all the vital organ in our body. So it wouldn't surprise you that patients with autonomic disorder, they might present with impairment of several domains at the same time. And this is why it's absolutely crucial a systematic evaluation in clinic. At the unit, sorry, this slide, it doesn't seem to show very well, but basically these are the patients. We see more than 3,000 new patients per year at the Autonomic Centre at UCLH. And you can see that we are seeing an increase in referral. This is just an average in the last 6 months. So more or less 5 new referral with long COVID syndrome per week. So what is the approach, how we approach this disorder? So the very big question in clinics is discriminating whether we are dealing with an autonomic failure or in intermittent paroxysmal dysfunction. And you will gain a lot of information from the clinical history itself. Whether we are dealing with a localized or a widespread autonomic dysfunction, the time course, if it's acute, chronic, stable or progressive, that will guide you regarding the etiology of the disease, and not to neglect a possible non-autonomic in nature disorder, like the effect of medication or other comorbidity like diabetes, which they can play a role in primary autonomic disorder as well. So I need to say the majority of the time, so the main complaint then it leads to a referral to our center in post-COVID, are patients then they do present with cardiovascular autonomic dysfunction. This is not to say that patients in long COVID, they don't have gastrointestinal or blood dysfunction. It's just that the cardiovascular autonomic dysfunction is a very prominent feature. So patients, they might present with a collapse, lightheadedness, dizziness, co-tongue pain, or with a more vague symptomatology, so with the symptoms only induced by exercise or by meal. So, why the blood pressure regulation is so key, and why patients, they might present with this dysfunction. So the way we regulate the blood pressure, on the left side, you see a cartoon where when we change position, there is a shift of blood volume between 500 and 1,000 milliliters of blood to the lower limbs. And the right side of the slide, you see the activation of several centers. So once there is a shift of the blood volume at the rostroventrolateral medulla, preganglionic or postganglionic neuron are activated, there is a release of noradrenaline, and this is how we are able to vasoconstrict the blood vessel when we are upright, maintaining the blood pressure. So if there is a lesion at any site of the autonomic nervous system, patient, they will end up in not able to maintain blood pressure when they are upright. However, so the orthostatic intolerance, which is the end of results, is quite heterogeneous. Yeah. So from one end of the spectrum, you have the severe disorder. So patients, they present with a neurogenic orthostatic hypotension. These are patients where there is a lesion of the autonomic nervous system, for example, patient with peripheral neuropathy, Parkinson's disease and autonomic failure, multiple system atrophy, or an autoimmune ganglionopathy. On the very end of the spectrum, you have a disorder that may be not autonomic in nature, even though the patient presents with orthostatic intolerance. And these, they do include drugs, which are very frequent in the elderly group, dehydration. And what you see in the middle is what actually we do see quite frequent in long COVID. So intermittent autonomic disorder, such as postural tachycardia syndrome and reflex syncope. But we will have a few cases so then we can discuss later on. So why does autonomic dysfunction might occur in long COVID syndrome? So this is still a matter of debate, but this is just to speculate on key possible pathophysiological mechanisms. So it's possible then we are observing a post-viral syndrome, as we do see in a patient with autoimmune autonomic ganglionopathy. There are patients that they do have a small fiber neuropathy, which might lead to an autonomic neuropathy, or patient with intermittent disorder, so with inappropriate sinus tachycardia or postural tachycardia syndrome. What we know so far in terms of literature, here I did list only few of them, but there are more case reports, and I will ask to pay attention particularly to the last paper, which is the Mayo Clinic experience, which is the only paper really summarizing a case series of patients. So you can see that they did describe a whole spectrum of disorder. Majority of them, they are intermittent autonomic dysfunction, which is reassuring in a way, even though we don't know the full natural history of the disease here. In terms of how we diagnose autonomic dysfunction, autonomic functional tests are definitely very informative, and they help us answering this key question, whether or not there is an autonomic dysfunction in the first place, if it does affect the parasympathetic, the sympathetic, or both, what is the degree of the autonomic failure, of the autonomic dysfunction, and it does guide us regarding possible treatment. So now we move on to our UK Autonomic Centre experience and what we have seen so far. I did summarize only the patients seen in the last 6 months. So to give you just an overview, on 35 patients tested, half of them they presented with abnormal autonomic dysfunction. So 40% with a new onset autonomic neural mediated syncope, then 26% with POTS, another 20% with initial orthostatic hypotension, and 6% of the patient either with a cardiovascular autonomic failure or a neuropathic phenotype. And we will see a few cases here. Sorry, I can't advance. Oh, here we go. So new onset autonomic mediated syncope. This is a 50-year-old man with a background of EDS3 and joint pain. And this is already a red flag because it might present as a risk factor for autonomic dysfunction. So post-COVID, the patient did develop intermittent symptoms with a chest tightness, breathlessness, dizziness on standing, and a time associated with a palpitation. Pre-COVID, the patient was able to manage daily walking and regular swimming session. Post-COVID, there was a worsening of the fatigue, finding very difficult to get out of the house and perform his day-to-day activity. So this is just to make the point that the huge impact on quality of life of this patient with the long COVID syndrome. On the left side, you see the documented vasovagal syncope that was on a tiltable test. Patient with POTS, so that is a big debate here. So what we meant with the POTS post-COVID-19, so patient they present with a constellation of symptoms, breathlessness, palpitation, chest discomfort, orthostatic intolerance, fatigue, many of them with a cognitive impairment, with a brain fog, which you have heard also from Dr. Zandy, thermodysregulation, joint and pain and muscle pain, and gastrointestinal dysfunction. So when the constellation of symptoms is associated with the excessive tachycardia, so excessive increase in heart rate when the patient is upright, which you see on the blood pressure and heart rate monitoring on the right side, this is what we are labeling at the moment as a POTS post-COVID-19. The problem is then we don't know. So if we compare this syndrome with what we know very well as idiopathic POTS, then we have been experiencing in the last 30 years, there are lots of commonality. So The POTS is the most common form of orthostatic intolerance, more female than male, which is the same than we are seeing in post-COVID. Onset between 15 and 50 years old. The constellation of symptoms are the same you have seen in the previous slide. We know that actually the POTS, the idiopathic POTS, is very well associated with an impairment of the idle domain. So it remains the big question, which I'm not sure that we can answer today, whether the POTS post-COVID is the same than the idiopathic POTS. And another problem with POTS is then is a label that it does describe the cardiovascular response, but in reality it's not very helpful in terms of etiology because the pathogenesis is very heterogeneous. So say POTS, it doesn't tell us where is the underlying pathology. Next one. So the initial orthostatic hypotension, we have seen a few patients with this phenotype. What we meant with that? So initial orthostatic hypotension is defined by transient blood pressure decrease within 15 seconds after the standing, with a drop in systolic more than 40 and diastolic more than 20, is fundamentally different from the neurogenic orthostatic hypotension. So as you can see here on the monitoring of the blood pressure on the left side of the slide, this is a continuous monitoring of the blood pressure on a standing test. And if we do the tilt, we are not able to catch the initial orthostatic hypotension because it's such a transient change. Then because the tilt is a passive and very slow change in posture, you may miss actually this drop in blood pressure. This is a 55-year-old woman. She developed lightheadedness and dizziness with standing and exertion. Other symptoms did include fatigue, headache, chest pain, and shortness of breath. Most recent loss of consciousness was July 2020. She stood from the bed and felt lightheaded and dizzy before briefly losing consciousness with a quick recovery. And the cardiology review was absolutely unremarkable. So this patient has been treated with a no pharmacological approach and she's doing better. Still not back to the baseline, but definitely with some improvement. Cardiovascular autonomic failure is something we have seen rarely in this patient group, but let me give you one example. 55-year-old man, post-COVID, he developed dizziness and lightheadedness with the postural changes. Symptoms, they were worse in the morning. He reported fatigue after a meal, no bladder issue nocturnal, long-standing diarrhea, and anhidrosis, so lack of sweating, and there were no neuropathic feature. So what you see in terms of testing on the left side, the upper panel is the classical neurogenic orthostatic hypotension, so significant drop in blood pressure without a compensatory tachycardia on tilt. We were able to document it on a 24-hour blood pressure profile, the drop, the orthostatic hypotension post-meal, and in response to 2 standing challenge. The catecholamines, they don't increase when the patient is upright, which is very consistent with the neurogenic nature of the OH. And last, neuropathic phenotype. So let me show you the patient. 38-year-old woman developed dyspnea at rest, shortness of breath with minimal exertion, for example, walking up the stairs at home or speaking on the phone. She had the fever, heat intolerance, dizziness, chest pain, lightheadedness, and palpitation. So there is a red flag here. So we were concerned about the fever and the anhidrosis. So we did several tests. I'm just showing you some of them. I hope you're going to believe me that on the normal tilt, there was a feature of POTS. We did perform a liquid meal challenge test, which is the test you see here. There was an exacerbation of the tachycardia post-meal, which we do see in many patients with POTS. On the 24-hour blood pressure profile, you can see the tachycardia with each of the standing challenge. And on supine exercise, there was an exacerbation of the tachycardia on standing post-exercise. So all of that fit the phenotype of postural tachycardia syndrome. But as I said, we were concerned about this profound heat intolerance and the fever. So we did raise the question of whether or not there was a neuropathic phenotype and whether or not there was a pseudomotor involvement. And you can see the next test. So we did perform a pseudomotor assessment. So we performed 2 tests. The one that you see on the left side, we call the dynamic sweat test. is a test, then it does evaluate a post-ganglionic function. Basically, we stimulated the skin with a pilocarpine, and each of these dots you see here is one sweat gland activated. You can see how dense and how widespread is the activation on a normal control, and how poor was in right arm and right leg in the patient. Then we perform what we call the thermoregulator sweat test, which give us an overall view of the global pseudomotor function. So we use a powder. This is our facility. We use a powder, then it does change color when the patient sweat. So the large area in yellow is because the patient was not able to sweat. So to combine the cardiovascular testing and the pseudomotor, we can definitely say that we are not dealing just with a cardiovascular feature of POTS. There is a neuropathic phenotype and a very pronounced anhidrosis in this patient. And to give you a little bit of idea in terms of follow-up, she's developing a very, very profound exercise intolerance. 6 months, and now we are 8 months later, she hasn't recovered. So how we approach with this patient? We are using the approach that we know that it works with POTS, with idiopathic POTS, but I can't tell you if that definitely will work in POTS post-COVID, yeah? So all the patients are assessed with a no pharmacological approach, and then in terms of treatment, it depends really what their cardiovascular profile is. So if they do have a normal high blood pressure profile, as in the hyperadrenergic POTS, we use a bisoprolol, propanolol, clonidine, or ivabradine, but I'm sure that Dr. Bell will be able to fill you in much more details. If there is a low blood pressure profile, we start with the fluidocortisone and we combine with the midodrine if appropriate. And in the very resistant patient, we use octreotide, which is a minimal invasive medication because it's subcutaneous injection. So just the key point. So POTS and vasovagal syncope, definitely they are the most frequent presentation post-COVID. This is not to say that we haven't seen other manifestations, but they are more rare. They can present with a constellation of symptoms involving several domains of the autonomic nervous system. These are intermittent disorders. They do have a heterogeneous etiology, and this is where more research needs to be done to establish the phenotype. Definitely these patients, they need a multidisciplinary approach and autonomic rehab. And the big question is related really to natural history, which I don't think we know well. What is the best treatment strategy? What is the underlying pathophysiology? Thank you very much for your attention.
Right. Okay. I don't know if hopefully you can see me and see my slides. So I've been listening to a lot of very interesting talks, and it's very, very clear that post-COVID syndrome is a hugely complex multimodal disease. Let's go to the next slide. So COVID infection, I was struck by a very similar slide in Akiko's presentation. COVID infection results in two very different subsets of outcomes. Well, three. One can be completely asymptomatic with excellent recovery without any kind of a sequelae, or at least any sequelae that we know about, versus what we recognize as moderate or severe respiratory disease that leads to inpatient admission and ventilation of some description, versus the more mild disease set, but with a persistent multi-system symptoms. And it's really that latter group that I want to concentrate on this afternoon. There's another issue, of course, and that is the question of definition and what do we call long COVID, what do we call this post-COVID syndrome? And I'm going to be using the UK NICE definition for this in respect to the duration, and we use 12 weeks or 3 months as a duration of symptoms before we make that diagnosis of post-COVID syndrome. Now, this slide really just shows the number of new cases that we were experiencing in the UK. And it's not really to really talk about the number of cases exactly. And certainly in that first wave, we were certainly under-diagnosing the number of individuals who are contracting COVID. But really what I wanted to make the point is that I'm still receiving referrals for individuals who got their COVID infection in March 2020, which was the first wave here in the UK. So what are the cardiovascular symptoms associated with post-COVID syndrome? Inappropriate sinus tachycardia, postural orthostatic tachycardia, as we've just been hearing from Valeria, exercise intolerance, dyspnea, and chest pain. Now, this is all part of a huge smorgasbord of symptoms that individuals with long COVID will experience. But the point being that chest pain and dyspnea particularly are two of the most common presentations with long COVID, and to which I would probably also add tachycardia as a significant contributor, probably in many case areas contributing up to about 25% of all presentations. So palpitations, fatigue, chest pain, dyspnea are the most frequently reported symptoms. And of course, this sort of tachycardia associated with post-COVID-19 infection has numerous overlaps with known tachycardia syndrome, sinus tachycardia, inappropriate sinus tachycardias, postural orthostatic syndrome. I'm going to add an extra circle to this slightly ungainly looking Venn diagram, and that's exercise intolerance. So exercise intolerance is a hugely common presentation to my clinic. People who just cannot get on with their life without feeling absolutely exhausted after very, very minimal levels of exertion. And this is typically characterized by very fast heart rates. So I thought I'd kick off with some definitions, as I think this is quite helpful for us to do. So inappropriate sinus tachycardia is defined as an average heart rate exceeding 90 beats per minute, typically on a 24-hour ECG recording, or a resting heart rate recorded by some other means of over 100 beats per minute. Postural orthostatic tachycardia, we've been hearing about, of course, but is defined by a sustained heart rate increase of over 30 beats per minute from a supine to standing position. And exercise intolerance. And as I've indicated, in this post-COVID syndrome is characterized by an increase of heart rate, often, in my experience, approaching over 80% of age-predicted peak heart rate with very minimal exertion. This is often associated with dyspnea and particularly associated with post-exertion fatigue. Patients frequently tell me that these symptoms are followed by profound lethargy and an inability to any kind of function lasting for potentially days after overexerting themselves. Chest pain. Well, actually, this is a broad range of symptoms as well. There's no one single type of chest pain. There's atypical chest pain that is a label that cardiologists frequently use for non-anginal chest pain. In other words, pains that can occur at almost any time. Then we have pleuritic chest pain, the pain on deep inspiration. Pericarditic pain, which is related to inflammation around the myocardium, and typically is quite postural from lying to standing. And there's a pseudoangina presentation too with this long COVID syndrome, where with exertion you will get chest pain, or strangely sometimes chest pain after exertion. So what kind of investigations can we do? Well, clinically, there's a number of tests that we can request. So blood tests are often done. They include CRP, the inflammatory marker, D-dimer, which is often elevated, particularly in the context of acute infection. Something called an NT-proBNP. I appreciate that many in the audience are not cardiologists, and this is a marker of heart failure. So when you're seeing a patient who is breathless, the NT-proBNP can be useful. because if the NT-proBNP is normal and you're breathless, then it's unlikely to be related to your heart function. But this is often elevated, particularly in the context of acute severe COVID. And we also measure something called HS, or high sensitivity troponin. And this is a marker of myocardial injury or leakage of this protein from heart muscles. Only heart muscle expresses troponin T. So if it's measured in the blood, it's leaking from your heart cells. We can also check electrocardiogram. We can do a 24-hour heart rhythm monitor with an ECG. And increasingly, we are able to do that with wearable devices, especially with smart watches of many descriptions, recording heart rhythm or heart rate over periods of time. We can do transthoracic echocardiogram, an echo scan of the heart to look at the structure and function of the myocardium, and cardiac MRI scans. I'll come to that in a second. So the electrocardiogram, and this is an example which basically shows sinus tachycardia, which in my practice is often one of the initial presentations and one of the very common findings in patients being referred. So, but we can also look for other features that might suggest some other, what we might call pathological arrhythmia, such as a Wolff-Parkinson-White, where we might see evidence of pre-excitation, a delta wave into the QRS complex, or evidence of other conditions of channelopathies, such as Brugada syndrome. So it is a useful screen for cardiologists to look at to exclude other causes of fast heart rate. So ECG can be useful to exclude arrhythmia. It'll confirm sinus tachycardia. And we can also sometimes see evidence of pericarditis or myocarditis by changes in the ST segments. We can also do 24-hour cardiac rhythm monitors. And so the postural orthostatic cardia syndrome is often associated. And you can see, I don't know how well this is coming across on your screens, but oftentimes you can see these brief, rapid accelerations marked by the arrows in the panel A. So this is associated with, this is where presumably an individual is going from a sitting or a supine position to a standing position, and you're seeing this rapid increase in heart rate. Or we can see, as we see in the lower panel here, an inappropriate sinus tachycardia, where the mean heart rate is consistently, or average heart rate is above 90 beats per minute. We may also see these other accelerations. If you also look at the left-hand side of this heart rhythm recorder in panel B, you can see heart rates up to 180 beats per minute. And this is likely associated with minimal exertion in this individual. Cardiac MRI. So again, you're not cardiologists and you may never have seen one of these scans, but you can imagine this is a cross-section through the chest. The top of the picture is the front of the chest, and in the center there we can see the heart. The right ventricle is the most central. The left ventricle is over to the left. You can see an L symbol on the right side of this panel. What we're looking for here is evidence of something called late gadolinium enhancement, where we're seeing fluid accumulation, which can be a part of fibrosis or acute inflammation. And we often find this in a very superficial or epicardial distribution. And this is associated with myocarditis. And I'm going to be talking a little bit more about myocarditis in a moment. So MRI is quite useful in clinically stable patients. Myocarditis generally has a good prognosis and something that we're not generally too concerned about. And cardiac MRI can be very helpful to confirm the diagnosis, and so we can modify risk and subsequent arrhythmias. So let's talk a little bit about the post-COVID clinic experience. And as I mentioned, I run the COVID cardiology clinic here at the UCLH. And what we've been doing for a lot of these unfortunate individuals who are complaining of chest pain is to arrange to have a cardiac MRI scan. And what we find is that 2/3 of the patients referred with chest pain in the long COVID clinic are female. They're typically in their mid-40s, and 2/3 report a very atypical chest pain. In other words, a chest pain that wouldn't necessarily associated with a cardiac cause. But other pain patterns were also described, including that pseudoangina. In other words, a pain associated with exertion. A quarter of the patients on the MRI imaging had evidence of myocarditis, of whom approximately a quarter had evidence of active inflammation. The myocarditis populations, in other words, the ones with myocarditis, were predominantly female, 80%. And again, in the mid to late 40s. And predominantly, in our population at least, Caucasian. But I think that's probably more a representation of our population than perhaps a Caucasian predisposition towards myocarditis. Certainly a great deal more work needs to be done here to examine this. We also found that left ventricular function, so heart function, was no difference in those with myocarditis versus those who did not have myocarditis. So the fundamental point here is that myocarditis is common in those with chest pain. It tends to affect females in the mid-40s, but it's a disease that generally appears to be mild and self-limiting. So that's great. So we can identify that people have symptoms. They have palpitations, they have exercise intolerance, they have chest pain. But what are we going to do about that? In my practice, I find that, as Valerie has already talked about, in those with good blood pressure, the inappropriate tachycardia and exercise intolerance can be managed quite effectively with pharmacotherapy, particularly bisoprolol or beta blocker, or avabradine, which is an I-funny channel inhibitor. And in my experience, these therapies are not long-term therapies. They are a bridge to recovery. So what I often find is that the intolerance is often associated with a physical deconditioning. And what we're looking to do is try and break the vicious cycle that leads to physical deconditioning by controlling the physical manifestations of tachycardia. And if you can do that, people find that they can do more and therefore can get their physical condition back. So that has been very, very helpful. In terms of orthostatic tachycardia, we would use standard POTS approaches, and we've heard a little bit about that. And in those with adequate blood pressure, absolutely, we would use bisoprolol or avabradine. For the chest pain, myocarditis, we've been using colchicine. And this has proven to be quite effective in managing chest pain and helping people get better. And in my experience, around about 80% of those managed with colchicine have a benefit from this anti-inflammatory therapy. But I think a couple of points need to be made. We need clinical trials. So none of this is evidence-based therapy at this moment in time. And part of the Stimulate's ICP study that Mike has already mentioned will examine some of these interventions that we are already administering, and looking to do that in a randomized control way, which I think will be vital going forward. And of course, we need more mechanistic studies, and we've been hearing a little bit about the vaccine studies and understanding about autoimmunity. And I think that's an important part of the milieu of long COVID syndrome. In terms of clinical investigation algorithms, you can imagine that a lot of work has been done here already. And this isn't actually the one that the investigation algorithm that we use at UCLH, but it's actually pretty similar to it, which is why I thought I'd put it up. But I would make some modifications to this. So mostly the patients with long COVID are going to be going down the right-hand side of this algorithm. So those with relatively mild initial COVID symptoms, in terms of respiratory symptoms at least. But then I would modify the duration of symptoms. So we'd increase that to 3 months rather than 21 days. Then we would probably follow this pathway, which I think is quite useful, but insert a multi-specialty, multidisciplinary meeting to discuss these patients. As others have alluded to, patients rarely present with any one symptom. They come with multiple systems. And in fact, 50% of patients, I understand, with long COVID will have 10 or more symptoms concurrently. So to imagine that I could manage this in a cardiology clinic on my own is unrealistic. I would also modify this with some advice in terms of medications. So those with chest pains, and tachycardia, I would absolutely advise bisoprolol or avabradine, and I would also consider colchicine. If the MRI shows evidence of myocarditis, one might be also be thinking about adding in either an ACE inhibitor or an ARB. And over on the side where the exercise intolerance or tachycardia is predominant, then we'll be thinking about the bisoprolol and ivabradine. So thank you very much for your attention.
So next, I would like to invite Dr. Petrino to give his talk.
Hi, everyone. It's an absolute pleasure to be here. I'm going to try and really burn through these slides so that there is time for questions moving forward. My name's David Petrino. I work at Mount Sinai, and I thought it might be helpful to give everyone a little bit of a sort of a kind of a history lesson in terms of this image here is Central Park in New York City in late Feb, early March of 2020, when we were hitting our first COVID surge, and overflow from the Mount Sinai Hospital went into tents into Central Park. And my team, which is very much involved in we call the division Rehabilitation Innovation, which is creating rapid responses and novel therapy paradigms. We saw this issue emerging where patients were unsure of where they should go when they contracted COVID-19, and it was leading to overflowing emergency departments and uncertain clinicians about how sick was too sick to bring people into a hospital. So we rapidly stood up a program that we called Precision Recovery, which was focused on acute symptom monitoring for COVID. Basically, people downloaded an app. The app asked them very basic questions on a daily basis, and we mailed out or hand-delivered a pulse oximeter to anyone in New York City who wanted to be involved in the program, so that we could coordinate their acute management of COVID, as they were in the going through the initial phases of infection. The program was really simple. Someone checked in on you daily. If you didn't have a smartphone, they called. If you did have a smartphone, they tracked your symptom responses and would only call if you were worsening. And then on a weekly basis, we would just check in and make sure you were moving in the right direction. Now, the reason I'm telling you all of this is because we started that up in March of 2020. And by May of 2020, we had about 10% of our patients who we were managing acutely started to manifest other symptoms. Now, the reason I think this is really important is because this is May. There were no large-scale patient support groups where people could get their story straight. You know, I know that there are a lot of long COVID denial or gaslighting situations going on out here. What I want to really express here is that in early May of 2020, we had patients showing up with highly consistent symptoms. And so this was when we immediately pivoted and realized that we needed to start a rehab program for persistent viral issues. Now, as we are all aware, there's a big sort of flow diagram of what can happen to you post-COVID. And, you know, I really think it's worth mentioning that other speakers, Akiko and Robert, have presented some really great stuff in a similar way to this. But I think it's really important to think about what we're treating. We talk about long COVID, and, you know, I'm putting long COVID down here in the bottom right under all of the different sequelae that you can have, that some of which have a medically explicable cause. You scan lungs, you see lung damage. You scan kidneys, you see kidney damage. We've all, you know, we've sort of hammered this home throughout this entire seminar. This is a multi-system issue. We started thinking about patients, regardless of whether they were severely, you know, hospitalized or non-hospitalized with their COVID. There were patients presenting with medically unexplained physical symptoms, where a lot of symptoms that they were expressing were showing up in the presence of normal or near normal, because I want to acknowledge that there is a lot of not normal testing going on, but it doesn't explain perfectly all of the symptoms that they're presenting to us with. So today we're going to be talking about this population of individuals that have symptoms that regular routine testing are not explaining well. This shouldn't be a surprise to any clinician because regular routine testing doesn't test everything, but people who are experiencing severely debilitating symptoms. So at a snapshot, I want to talk about rough demographics from a few hundred cases that we polled, and really narrow in on a couple of things. So as you can see here, we're seeing majority female, median age similar to what we've heard earlier of 43 years of age. And COVID status, I want to zero in on because we're seeing around 50-50 in terms of people who have seroconverted versus people who have not, or people who had a positive PCR test versus people who do not. I want to draw your attention to a few things, first of all. So in terms of notable comorbidities, what you see here, 13% of people with anxiety, pre-existing depression from their medical records. These are lower rates than the general population. So once again, if people want to push a narrative of mental illness, it won't work here because these individuals previous to COVID had lower than what we would expect to see in the average population of lower levels of anxiety and depression in their pre-COVID medical histories. Another thing I want to point out is this COVID status. The CDC recently put out guidelines around COVID status stating that 36% of COVID patients do not seroconvert, i.e. will not test positive on an antibody test. And let's also point out the fact that PCR tests were hard to achieve early on, and then many people were getting false negatives. So all of this to say, do not turn people away with long COVID symptoms just because of their PCR or antibody status. That was an early mistake that should be corrected at this point. I also want to point out that although, in our surveys, we're seeing an overrepresentation of white patients showing up to our clinics, we do not think that this is epidemiologically relevant. In different populations with different biases to access to healthcare, we see just as many other races presenting with long COVID. So this should not be viewed as something that is demographic specific. This should be viewed as disparities in health that we need to rapidly address. So I just wanted to point those three issues out. This is a list of all of the persistent symptoms that we've been seeing. I'm actually just going to move right on because I think a lot of people have already done a detailed description of that. So what I do want to talk about is for the clinicians on the audience, know your history when you start to work with long COVID patients. So be aware that there is a long history of gaslighting in patients who have conditions with invisible symptoms. Just because you can't measure it on a standard test does not mean it is not there. Also understand that we can learn from post-viral communities, the Lyme disease community, the ME/CFS community, and that these patients have been told that exercise and psychology treats ME/CFS for decades, and these things have caused demonstrable harm and worsened symptoms and increased disability. So these are things that we should be aware and be thoughtful of as a new generation of post-viral illness patients are emerging, and we want to treat them effectively. So moving on to treatment pathways for patients with long COVID. The way that we're managing it within our clinic is as follows. So the first thing we do is we have an initial evaluation with a clinician. Our physician is usually a rehab doc. That's just how we're doing it, a physiatrist. That's how we're doing it at Mount Sinai. But as many have said, this takes a village. We need multidisciplinary approaches. And it doesn't really matter who's leading the approach so long as everyone's talking. In our initial evaluation, what we typically do with our physicians is we get a sense of what the major symptoms are. We give a lot of education around managing autonomic nervous system symptoms, because we do see a real skew toward dysautonomia. and we give behavioral advice, such as for energy management, such as pacing. From there, we send patients off for cardiac clearance with an echocardiogram and ECG, EKG. We, just as Dr. Bell mentioned, we need to be really clear that so many of these patients are showing up to our doorstep with fatigue, shortness of breath, chest pain. You need to clear the heart. You can't just assume that this is long COVID. You need to make sure that there is not underlying cardiac pathology that could be causing these symptoms. And we do not let anyone begin rehab until we have cleared that. We then start really building out the behavioral strategies to get symptom attacks under control. We work with, like I mentioned, strategies for dysautonomia, pacing for energy conservation, and then we build in breathwork coaching as a form of prehabilitation. One of the most interesting findings we've seen in a proportion of our patients is a majority of our patients are I've lost my slides, everybody. Oh, here we go. A majority of our patients are showing up hypocapnic, meaning low CO2 levels. So our breathwork protocol to increase CO2 levels and increase CO2 tolerance has been very helpful for our patient population with long COVID, and we've seen a lot of positive responses to that breathwork protocol. We then refer on to additional specialties as needed. So, psychology, nutrition, other specialties, cardiology, anything that is needed for a multidisciplinary approach. And then at that point, we refer on to physical therapy for autonomic conditioning therapy and dysautonomia rehabilitation. At this point, I really want to just point out for all of the patients listening, groups that we have had success with. So MyMe is a group that we've had success with. They are a behavioral health coaching platform that works primarily with autoimmune conditions. Our patients have reported to us that this group is really, really helpful for them. The website is myme.com. Stasis is our breathwork program, and we've been working with the breathwork coaches from Stasis for a long time. Our patients similarly have had very positive responses to this. A quick brief word about autonomic conditioning therapy. We built off of existing autonomic rehabilitation programs to build out a novel program for our long COVID patients. The main differentiator between our program and existing dysautonomia rehab is we started at a much lower level of intensity for the rehabilitation. So our initial observation early on was that most patients would get severely exacerbated if we tried to start with existing intensities of autonomic rehabilitation, such as the Levine protocol. We had to taper things right back to a much lower level of activity. To quickly show you some data from a few dozen patients, what we can see is that about 65 after 65 days of rehabilitation, we're seeing a significant reduction in self-reported fatigue from patients. And once we hit 100 days, on average, 100 days of rehabilitation and a point of discharge, we're actually starting to see that patients are able to engage in actual exercise, and we're starting to see functional improvements. So what we're seeing here is in the 6-minute walk test, we're actually seeing that patients are able to complete the 6-minute walk test without exacerbation and are showing significant gains in walking speed, symptom intensity, both at rest and during activity. So when I say working, is this working? Let me really be clear on what we think is going on. What we're presenting is that when you perform very skilled and careful autonomic rehabilitation, we appear to be easing symptoms of long COVID and increasing function. But it requires intensive rehab over a long period of time. We have observed relapses in patients a long time after we have discharged them, which indicates to us that we are managing symptoms with rehabilitation. We are not necessarily addressing the underlying cause. So with that, I really want to shout out to the work that Akiko is doing in collaboration with us and others to look for the pathophysiology, to understand why these symptoms are emerging and how to manage them in a more long-term viable way. I also want to really point out that if you are looking for additional resources, Long COVID Physio have been really phenomenal advocates, and they have a wonderful website where you can see lots of education and resources for rehabilitation and symptom management. Also, the American Association of Physical Medicine and Rehabilitation are starting to release consensus guidelines that many clinicians might find useful. So at that point, I'd just like to thank the amazing team of individuals that have been helping me out, our patients who have been incredibly giving of their time, the RTW Foundation that has funded a lot of this work and allowed us to keep doing this work. And you can follow us on our various social media tags. So thanks very much.
Wow, I just want to thank everyone for their amazing presentations. It has been a really good webcast, and I think that the audience will have really benefited from it. So thank you so much for providing your time. I think we are now going to take some questions. I know we're overrunning a little bit, but I think we're most of us are able to stay. Dr. Petrino, I know sadly you've got to go, but thank you so much for your contribution anyway. But we will now try and take some questions from the audience. I know that lots of people have been submitting them. I think we have now got over 100 comments and questions. So I'm just going to try and pull them together into summary questions that cover the similar topics to what people have been touching on. I just want to say to a lot of the patients, I'm really sorry, but we're not going to be able to answer specific questions related to your condition or symptoms. I know how anxiety making it is when you can't get the medical care that you need and you are really looking to know who to be referred to. I also recognise that there are an awful lot of discrepancies in who can access what levels of care, certainly in the UK, but I know that in the US as well, the differences in long COVID clinics and what you can access geographically are problematic. But I don't think I can really take any specific questions on referrals, but we will try and cover the main themes of the topics that have been listed in the Q&A section that people have written. So to start with, I wanted to ask particularly Dr. Zandy about cognitive issues. There have been several questions on cognitive issues, and they do appear to be very common and described very frequently by people in the long COVID support groups. And so there are specific questions about when people should be investigated and how should they be investigated. And in the absence of neuropsychiatrists and neuropsychologists, or given that they are very limited in number, is occupational therapy a good substitute for assessing people? And how can we help people who are really struggling to return to their employment because of cognitive dysfunction?
Yeah, thank you. And I'll give a very short answer just with the number of questions that we've got. So I think, like anything in medicine, looking for red flags should prompt investigation and specialist referral. But yeah, occupational therapists, primary care physicians can get a good handle on who needs to have investigation, who needs to be referred on or not. And I think the unlikely, they're quite rare. That's the first thing to say, but I think they can masquerade in a long COVID clinic. So it's important to think about these things. So encephalitis, seizures, fever, a sudden change in mental status, the family noticing that the personality is very different, something we call accelerated forgetting, where we could have a conversation now, but half an hour later, you just you've not been able to make that episodic memory of remembering an event or remembering a piece of information. So quite different from working memory or short-term memory. which is just the ability, if I gave you a telephone number now and said, walk across the room, can you type in the phone number? That's our frontal working memory. And I think if somebody is confused and encephalopathic, they're hallucinating, or there are any psychiatric type of red flags, they're suicidal, or they're those kind of things, they need investigation. So I think, what many of us are left with people who say, well, I don't have any of those red flags, and I'm at work, but I'm just feeling this cognitive wall, and I'm really having cognitive fatigue. I think if that's substantial, I know this is a woolly answer, but if it's really impacting on quality of life after 1 month after COVID, and certainly after 3 months, then, and this is something we're exploring in our study, I think that does warrant at least an OT assessment and some memory testing, and a physician to see the patient face to face as well. I think a lot of these things do need to be done in person. What was the second question? Sorry, can you go to that?
So it was largely about how can we help people to get back to their normal employment and recover so that they are able to do their jobs again. Yeah,
and I think good occupational health involvement. I saw one of the questions, if people have got jobs where they're, driving, or they're, they have serious responsibility, they should have a very low threshold for being assessed and taking lots of precautions, lots of safety precautions. There's this rule of thumb, 60% rule for avoiding post-exertional malaise physically. And many of the people we see seem to know about that for physical stuff, but still think that they can handle 6 hours of Zoom calls or, lots of cognitive work without breaks. So we'd say take lots of breaks from the screen, and really be selective in what you need to do. Do you really need to send emails? Do you really need to do a face-to-face conference call or video call? And try and eliminate as much as you can that kind of stuff. But I think close discussion with your employers, you've got rights, and making sure that you're safe at your work is really important.
Okay, thank you. I think we will ask, we've had quite a few questions on vaccination. So Dr. Iwasaki, I might direct these to you. So it seems that one of the questions we have is a small rate of long COVID patients are experiencing worsened symptoms after receiving their first vaccination. What do we think that might be the underlying reason behind that, and how can we help them to improve their symptoms? And the other question, which is very similar, is that there is some data that suggests some patients who are vaccinated show a reduction in symptoms, whilst others show a worsening of symptoms. And is there a way that, if you look at the data in a more granular way, that you can distinguish between who might be having a worse response following vaccination and who might be improving a little bit following vaccination?
Right. So this is absolutely at the forefront of a lot of long COVID patients, because many of them feel afraid to get the vaccine. And right now, we do not understand what distinguishes people who are going to feel better versus worse. We're just trying to monitor the responses and then correlate the changes in the immune response to those changes in the symptom. But unfortunately, I cannot advise anyone about the likelihood of them feeling better versus worse at this point.
Okay, thank you.
I think can I add to that? Because
yes.
This is something which I think we all see on all of our COVID clinics. And one of the observations I don't think you can, I have not seen anything that would predict who's going to get a reaction from the COVID vaccines. Hugely variable. Most people will not have any kind of reaction to it at all. Some people will have flares of symptomatology, and in my case, obviously, I'm more interested in cardiovascular system, in which case I see flares of chest pain. What I would say is that these people get better. So absolutely, you should absolutely go for your vaccination. I think that's going to be the imperative message. And just anecdotally, I was speaking to a patient this morning who actually found that the second vaccine actually made her better. So it's, I mean, it's a hugely variable response, but generally speaking, the flares that you get as a consequence of the vaccination tends to be mild and transient.
Thank you. And I think one of the thoughts on this also is that while people may be concerned about having the vaccine and that it may make them worse, we also don't know what might happen were you to be re-exposed to COVID and were you to be infected again, and whether that might actually be worse than having the vaccine. And I think we simply don't really have the answers to those questions yet. But the likelihood is that a second infection may well be worse than having the vaccine itself. And actually, while you're there, Dr. Bell, one of the questions I was going to ask or has been flagged is about the use of cardiac MRI. And I'm sure you all know that I pretend to be a fly on the wall as a clinician on some of the long COVID clinician discussions that happen in the UK. And certainly there are many cardiologists who seem to argue that we shouldn't be doing cardiac MRI in all of these patients who have long COVID symptoms. And it almost seems to be something that's slightly dividing the cardiology community. And maybe you could just touch on why that's the case and also how important you think cardiac MRI is in this investigation.
Well, absolutely. I mean, the trouble is with MRI, it's not a very available diagnostic piece of kit. Not everybody is going to have, not every single hospital will have access to cardiac MRI, so not every center will have it. And in actual fact, and what information are you going to derive from doing the MRI in the first place? And if it's going to change management, then absolutely you should have an MRI. And part of the reason why we have been so active is because we do have an MRI, we do have a magnet. And I was particularly interested to know what exactly the chest pain actually meant. And if there is something to be seen there, how important is it? And I would say from our experience and probably experience of other centers and from colleagues, discussing with colleagues, that the sequelae tends to be very mild and limited, which is what I mentioned in my slides. So if MRI is not going to tell you whether it's going to tell you whether you've got myocarditis, yes, it is going to do that. But generally speaking, what we see is a very mild disease. And the way that we're managing that currently would be with the anti-inflammatory, such as colchicine, and generally speaking, that is sufficient. So an MRI wouldn't necessarily change your management strategy if what you're going to be doing for these individuals with chest discomfort is essentially the same. So I think the purpose of doing MRI up front and early in the course of this is to truly understand what the mechanism of that chest pain is. Once you've established that and understand that actually this, in this cohort at least, is mild. It's not necessarily mild in all cohorts, but in the cohort that we've been discussing this evening is mild. I don't think you would necessarily need to do MRI as a routine investigation. I think you can probably get on and manage and treat these individuals on the presumptive diagnosis of some degree of cardiac inflammation.
Okay, thank you. I think we have an antibody question, which probably I'll direct at Dr. Iwasaki. Because you've already touched on this, but does the induction of a broad autoantibody repertoire occur after other viral infections as well, or is this a very specific feature related to COVID-19?
Right. We're currently testing whether other respiratory viral infections might also lead to development of autoantibodies. We don't have an answer yet. But autoantibodies are not very rare with respect to development with inflammatory diseases, including viral infections. Many of these autoantibodies are transient in the case of inflammation and infection, but we're following some of these COVID patients for over a year now, and some of them still retain the autoantibodies. So I think long-term monitoring and understanding the pathophysiology of these autoantibodies are going to be important.
Great, thank you. And lastly, I'd just like to ask a question to Dr. Iodice, just about autonomic dysfunction, and people have been asking when, sort of, at what point should people be being referred for further investigations? Obviously, there's some investigations that could be done in a primary care setting, but at what point should patients be referred for further investigation? And I think there's another part to that, which maybe Dr. Bell would like to answer afterwards, I don't know, but people asking how does exercise tolerance improve when you suppress the heart rate in people with a sort of an inappropriate sinus tachycardia or a POTS-like syndrome?
Sure. So, Natalie, so to answer the first question, so I don't think in terms of feasibility, obviously the Autonomic Centre, they are not available, easily available everywhere in any trust. So, and I don't think that all the patients post-COVID, they will need to be seen by an autonomic specialist. So at the moment, the pathway for us is then, majority of these patients with the POTS, so new onset autonomic neural-mediated syncope, they do respond to no pharmacological measure, to initial medication with beta blocker or midodrine. The GP in primary care, definitely a standing test is quite useful because you can get a degree of the extent of the tachycardia, so measuring the autonomic vitals, so blood pressure and heart rate when they are lying down, and on 10 minutes of standing, it does help. The 24-hour blood pressure profile also is something, quite easy and available everywhere. And you can get a lot of insight if it's associated with a diary. So at the moment, we are suggesting that actually patients then do not respond to no pharmacological approach or do not respond to initial treatment to be referred. If there are atypical features, so patient does have a possibility of an autoimmune disorder, or if there are frequent falls or frequent syncopal episodes, that is another point for referral to the unit, yeah? So this is how we are managing this cohort at the moment.
So coming to the second question, I totally agree with what Valerie has just said, by the way. I think that's absolutely the sensible approach. The exercise intolerance question, I think, is a little different. This is usually in an individual who has a very high resting heart rate. And I think this is oftentimes not necessarily autonomic dysfunction per se, but it seems to be a dysregulation or disproportionate response to a level of autonomic function. So you have a very high resting heart rate. And when you exert yourself, if you get to, close to peak predicted heart rate, so you have your predicted heart rate varies with age. So if you're older, you won't necessarily get to the same heart rate as, say, a very young, fit individual. But if you're getting your heart rate up to rates of 180 beats per minute, that'll actually affect your cardiac output. So when one looks at, this is a bit of a physiology discussion, I guess, but so if you have a normal resting heart rate and you want to increase your exercise capacity, increase your cardiac output, there's multiple different ways that you can go about doing that. Increasing heart rate is part of it. Increasing your stroke volume by increasing venous return is part of it. And but in these individuals, often the venous return isn't necessarily increasing as it should. And with a very, very fast heart rate, you've actually got less ventricular filling time. So actually your cardiac output with very fast heart rate actually tends to fall. So I think that's part of the symptomatology. If you get very fast heart rates and tachycardia, your cardiac output isn't as good as it could be, and you will feel dreadful as a consequence of that. Plus, there's the aspect of inappropriateness. So you're aware of your heart rate racing, and that's a very uncomfortable thing. And I saw one of the other mentions in the questions about being very aware of your pulse, and something which is really quite uncomfortable, even if the heart rate is relatively normal. And again, I think it's just a sort of a cardiac awareness which is uncomfortable, and that too can probably be managed with pharmacotherapy if non-pharmacotherapy approaches do not work. So I think that's partly how I would address that question. The longer-term fatigue as a consequence of that, I think, much harder to understand, and that's something which we need to work on more to try and tease apart.
Great. Well, thank you very much, everyone, for sharing your insights and for this the great discussion we've just had. I also really want to thank the audience for attending and for participating. And lastly, I want to thank MGH Life Sciences and the International Society for Vaccines for making today's webcast possible. So hope to see you next time, and many thanks and goodbye.
Goodbye.